really blessed with coming to the right place, that's for sure.
His compassion was so different than any other doctor.
Jody Roberts struggled for decades to find answers and a solution, all the while struggling to breathe and swallow. The diagnosis and the heart surgeon here at the health system who finally fixed her problem in just one day. Good morning, I'm Alexis Delcid. Welcome back to All Things Heart. We know trust is crucial. It's a crucial factor in our medical care. And in her search for a second opinion, Jody Roberts finally found the team she trusted right here at the health system. And because of the care she got here, Jody has her life back. But first, we have some morning rounds. Getting a CT scan makes some people nervous, understandably. You're in that small tube with the loud noises, trying not to move. Well, now imagine a toddler going through that, or a baby. Pediatric patients are often sedated because of the challenges. Now, new research shows that little ones can be sedated with a nasal spray instead of a needle. We're joined by Dr. Sean Sood. He's our pediatric critical care physician here at the health system at the University of Kansas Health System. To so many patients, Dr. Sood, fewer needles for their kids is going to sound pretty good.
Yes, we're trying to make things seamless for both the kids and their parents.
We used an example at the top of this about a CT scan, but what are some of the other situations where you might need a child to stay absolutely still?
Yeah, other indications would be an MRI or an echocardiogram, so an ultrasound of a child's heart, and auditory brainstem response test, so a hearing test for newborns and infants. These are all tests that the results are better if the child can stay still, and often they need sedation for that.
Well, I got to tell you, we've talked to some of your former patients, and they always talk about how calm you are and how gentle you are with their little ones, so I'm sure that helps a lot. When did nasal spray, though, become an option, and then why haven't we heard more about this?
Yeah, the nasal spray was only approved in the last 4 years for pediatric sedations, and a lot of health systems and hospitals, they protocolize things. A child needs a CT scan, we're going to do X and Y. But here at the University of Kansas Health System, we like to think we do a personalized approach to each patient. So what would be efficacious for this child and also safe?
So you're also the co-author of a new study that was published in the Journal of Pediatric Intensive Care. What was the focus of your study?
Yeah, it was really about the safety of this medication. It's called Precedex. It's a intranasal spray that you can give a child. It's not an opioid. And so when we are referred by pediatricians in the community that, hey, our patient needs a CT scan or an MRI or an echocardiogram, and the child can't sit still for the procedure or test, when they come in and we evaluate them, we wanted to see if intranasal Precedex would be a viable option. And because it's such a new drug, we wanted to know the safety profile of it. So we monitored so many things, like how is the patient's oxygen level doing? How's the patient's blood pressure? Do they have any behavioral response to this medication, like any agitation? And we found that this medication works really well for certain patients, and over a 4-year time period, we found that the medication was safe and efficacious, and it's a lot cleaner medication than an opioid or narcotic.
Is this something that a parent or caregiver who's watching right now could request for their child?
Absolutely. And so before any medication's administered, you're going to check in with your critical care physician or anesthesiologist and go over the plan. And if the procedure is non-invasive in nature, doesn't cause any pain, a parent can absolutely request intranasal Precedex.
One last question, because there are grown-ups who don't like needles as well. Is this also available for adults?
It is. It is. So our study that we looked at and performed here just focused on pediatric patients, but this was used in adult patients prior to being studied in pediatric patients.
That's going to be welcome news for a huge portion of the population. Dr. Sood, thank you so much.
Thank you.
And now to today's featured patient on All Things Heart, Jody Roberts. She has always had trouble breathing, and for years she was treated for asthma. But that wasn't the cause of her struggles. It turns out she had an aneurysm on her aortic arch that was compressing her esophagus and her trachea. When you ask Steve Roberts to describe his wife Jody, the answer's immediate.
She's tough. I mean, this is the tough woman.
And Jody is just as quick directing the admiration right back at Steve.
He's been very supportive. Best caregiver ever.
The trouble began brewing for Jody before she was even born.
My heart was literally backwards. Everything was going this way instead of that way.
In 2015, she went to a nearby emergency department because she was having trouble swallowing.
They put a scope down my throat. They saw an indention in my throat.
Her aortic arch had developed an aneurysm, and because of her unique anatomy, that aneurysm was compressing her esophagus and her trachea. And this is when Jody also learned her lifelong asthma diagnosis was a misdiagnosis.
Every year, problems breathing. They said that I had athletic asthma, but it was actually my heart.
In 2020, she went to a hospital not affiliated with the University of Kansas Health System for surgery to correct the aneurysm. It was a brutal recovery. Jody says she was on a respirator for 2 weeks after, and when she finally got out of the hospital, she and her husband were disheartened. Jody still felt awful, like something was still caught in her throat.
I still had issues. Thought it was just in my mind.
Yeah, because they had it fixed.
Yeah.
As far as we knew.
As far as I knew, it was fixed.
Then the pandemic hit, and then the aftermath, and Jody limped along another 4 years in terrible discomfort, until finally she came to the University of Kansas Health System and was stunned at what the medical team here told her.
They ended up finding I still had a protrusion in my esophagus, which was causing me not to be able to swallow and having trouble talking and breathing.
Further scans revealed the aneurysm had never been repaired.
I'm like, what are you talking about?
Yes.
What are you talking about that was already supposed to be done?
Right.
Jody needed a second surgery, and she needed it quickly, which was nerve-wracking for both Jody and Steve, to say the least.
Nervous as hell. Nervous. I was nervous.
Yeah, same feelings came back. Are we going to do it again? Is this going to happen again? You know, is she going to struggle with the same thing?
But they say the nerves melted away when they met cardiothoracic surgeon Dr. Todd Crawford.
He had that calming effect. It's like, everything's gonna be okay. We'll get it fixed.
In December of 2024, just a few days before Christmas, Dr. Crawford performed her surgery. Everything went perfectly. Even better, Jody was home by New Year's Eve. And now, just a few months later, she and Steve are planning for their next adventures.
Oh, I have a bucket list of things to do. Like zip lining and go way out there, go parasailing.
Yeah.
Yeah, I want to do all that.
Great. As long as I can hold up. I have to keep up with her now.
Jody Roberts joins us here in the studio today, along with our cardiothoracic surgeon, Dr. Todd Crawford. Thank you both for being here.
Thank you.
Jody, how are you feeling? You're beaming. You've been so
Yes.
happy since you walked in.
Oh, yes. I'm feeling really good.
And you go back to work when?
Monday.
Monday's
So
your big
I'm
day
excited.
back.
Yeah.
Are you feeling like you're ready to get back to everything?
Oh, yeah. I definitely am. I'm ready to get going and
Take on the world?
Yes.
What's on your bucket list next, most immediately?
Zip lining, I think.
And does Steve know about that?
No.
He does now.
Yeah.
He does now. Steve, you're going ziplining. Dr. Crawford, Jody was born with such a unique heart situation. Can you explain to us what were the complications she was born with?
Yeah, so Jody was born with a right-sided aortic arch, which is a rare anatomical variant that occurs in about 1 in 10,000 people in this country. And so, you know, to get back to the embryologic development of the heart and the great vessels, the aorta actually starts as 2 tubes on either side. So you have a dorsal left aorta and a dorsal right aorta. And in her case, the dorsal left aorta involuted or kind of failed to form, and the dorsal right aorta persisted, which is what gave rise to this right-sided aortic arch.
Okay, so she had one tube.
Exactly,
Yeah.
and so instead of her aorta turning and going down the left side of her back, it went down the right side, and then the branch to her left arm and the back of her left brain, the left subclavian artery, actually came off the right side. So
Wow.
even beyond where the other branches to her brain came off.
You are a unique person.
Yes.
In every way. The pandemic, let's talk about that, because the pandemic was tough on everyone without medical struggles. You went through it in extreme discomfort after your first surgery somewhere else. What made you finally seek out a second opinion that led you to Dr. Crawford?
I still was having difficulty swallowing. I couldn't understand it, so I went to the doctor to get an EGD. And when they did that EGD, that's when they found something was pushing on my esophagus. So they sent me over to KU for another test to see exactly what it was. And they found out it was my arch with the aneurysm.
Pressing on your trachea and your esophagus, so it
Yeah.
was compressing everything, which is why you were in such discomfort.
Yeah.
So, Dr. Crawford, what would have happened if Jody had just lived with this and not finally met you?
Yeah. Well, to kind of explain what we were seeing on her imaging studies, when she had her swallow study or her esophagram, it demonstrated posterior compression. So something on the outside was pushing the back of her esophagus in that was limiting her ability to swallow. And that's a fairly classic presentation when you have an abnormal arch anatomy that has a vessel running behind the esophagus. So we call it a retroesophageal structure, and in this case it was an aberrant left subclavian artery. So if we didn't fix it, she would continue to struggle with swallowing and this compression of her airway as well, that essentially was manifesting like reactive airway disease, which is probably why she was diagnosed with asthma.
Your whole life?
Yeah.
Gosh, how frustrating.
Yeah.
How immediately after you were able to diagnose Jody did you need to perform that surgery?
Yeah, you know, there was not really urgency or emergency related to the finding. Rather, it was to alleviate her symptoms. Now, she also had aneurysmal changes around the area where this aberrant subclavian artery that was coming off that potentially put you at risk for an aortic complication like a dissection, but that wasn't the most pressing need. It was really her symptoms that drove us to intervene.
How quickly after waking up from the surgery did you feel relief?
I think immediately, really. I could swallow. I wasn't having any problems.
I'm sitting here taking deep breaths when I talk to you because I'm trying to imagine what that would feel like with that pressing on your trachea.
It's like having some just stuck in your throat, like a bunch of pills or food or.
Oh gosh.
Yeah, it was.
And you lived like that
Yeah.
for years
Yeah.
through the pandemic.
Oh yeah.
So you couldn't even like eat to make yourself feel better during all that
No,
stress because you were having
no.
trouble swallowing.
Right.
We have some really interesting videos we'd like Dr. Crawford, we'd love for you to walk us through. Let's start with this scan from before Jody's surgery. What is happening there pre-surgery?
Yeah, so, you know, ordinarily the aortic arch comes out, the ascending aorta comes out and then turns around and goes down the back on the left side. So in this picture, this is actually the left side of the chest, this is the right. And in Jody, you can see that the arch turns the opposite direction, comes down the right side, and then you see the branch to her left carotid, her right subclavian arteries, and then this is her left subclavian artery coming off behind the esophagus from the right side.
I was going to ask, where is the esophagus on that, and then where's the aneurysm?
So there's the
pressing on it?
airway, and then the esophagus, you can barely see, it's compressed so tight, and this is what's called the diverticulum of Commerell, which is what gives rise to that aberrant left subclavian artery, which is what's compressing the esophagus right there.
And then post-surgery, explain to us what you fixed here.
Yeah, so, you know, essentially we had to come up with a creative solution. We knew she'd have significant scar tissue on the left side from her previous operation. And going through a sternotomy to get there would be treacherous because essentially I'd be working through a tiny space between the airway, the esophagus, and her aorta. So,
Can you explain to our viewers when you say sternotomy, where on your body would you be going?
Yeah, so there's a couple ways to approach this. Typically we go through the left chest to deal with these abnormal arch variants, but in her case she had already had an approach through the left chest. And the other option is to go through the front, through a sternotomy, and then you're working up in the neck, because that's where this is located, this compression. But alternatively, one day we were seeing her in clinic, and Dr. Biggs and I were kind of bouncing ideas off of each other, and we said, well, what if we went through the right chest? We cooled her down, we shut off all blood flow, opened up her aorta, and just cut this diverticulum out as an island, and then closed it, and then replaced that segment of aorta with graft. Said
wow.
That would depressurize this diverticulum that's pushing on her esophagus.
Jody, you're smiling when you're hearing
Yeah.
Dr. Crawford talk about this. What makes you smile?
It's just so outstanding. It's just like a miracle. It's just neat to listen to him talk about what they did.
Mm-hmm.
Yeah.
Brainstorming.
Yes. Oh, it was, yeah.
We have a picture we'd love to share with our viewers. Now, the next picture we're going to show you is graphic. It's medical, it's graphic. So if you're squeamish, close your eyes right now. We will let you know when you can open them again. Okay, this is a picture taken of Jody's heart after the procedure. Dr. Crawford, can you explain what we're seeing here?
Yeah.
Wow.
Yeah, so, essentially there's two components to this operation. First is to restore blood flow to the left arm and the back of the left brain. And we did that by doing a carotid subclavian bypass, which was performed by my colleague, Dr. Biggs. And so that takes blood from the left carotid artery to the left subclavian artery. And then he actually divided the subclavian artery proximal or before that new connection, so that we eliminated blood flow coming back into the diverticulum from the left side. Then in the open operation, which we did a couple days later, we did a large thoracotomy, which is an incision through the right side of the chest. Mm-hmm. We had to be really high when we entered through the rib spaces so that we could get all the way up to the arch.
So you had to enter in the upper ribs, like way up there?
Exactly.
Below the armpit.
Yeah, in the third intercostal space, which is really high. So we had to lift the scapula up to get there.
Wow.
And then we opened up her right groin and put her on cardiopulmonary bypass so that we could cool her down. And so during...
Is that her, that's her, sorry to interrupt. At what point was this picture taken? And
this is at the very end, when we're all done. But essentially, once we had cooled her down so that her brain no longer required oxygen, we shut everything off. For about 20 minutes, we opened up her aorta. We could clearly see this diverticulum. We cut it out just like an island, and then we just sewed it together so that there was no more blood flow entering it, so it's not pressurized anymore. Dr. Biggs had already controlled it on the other side in the left neck, and so now we had it isolated. And then we replaced that area of aorta, probably 10 centimeters worth of descending aorta, with this polyester graft. And then warmed her back up by turning back on the bypass machine, and her heart started back up and took her off, and she did great.
That is so cool, clearly. To our squeamish audience, you can open your eyes again. The image is off the screen. Sorry for having you close your eyes for that long, but it's for good reason. Jody, real quick, when was the first time you saw that picture?
It was right after surgery. It was a couple days, I think.
Yeah.
Did you ask to see it? Like, say, did you take any pictures?
No, but he knew I was
Yeah.
a geek about medical stuff, so.
Did you take it for Jody because you knew she'd be curious?
Yeah.
Yeah, that
I mean, this is a unique case. This is not something that we do every day, every week, every year. So.
Right.
Have you ever seen a case like Jody's before?
I have, and I've approached it in different ways. This was kind of a more novel approach, but it was right for this situation. There's not a great way to approach a vessel of that size, and obviously if you have trouble with bleeding, it can be catastrophic. That's a massive vessel under arterial pressure. So, we were pretty thoughtful about our approach to it, and took our time, and she had a great outcome.
How long have you been a medical geek, in your terms?
Oh, always, always.
You just never thought you'd be on this end of it?
No, I really didn't.
Is it unique to have a patient that wants pictures taken to see them?
Not necessarily. Increasingly, patients are interested in seeing what's going on the inside.
I'd be curious too. I think it's
Yeah.
interesting. We love when our viewers send questions, and we know we have plenty of them coming in. We love it when you do this. If you have a question or if you have a comment that you'd like us to read out loud, you can send it to us right now in real time on the Facebook page, our All Things Heart email, or on YouTube in the chat. All the links and how you can connect with us are here on your screen. Dr. Crawford, this was a second surgery for Jody. The first was done someplace else. What kind of questions would you suggest that people ask their doctors post-surgery?
Yeah, I mean, again, this is a rare problem and one that's extremely difficult to treat, very high risk. There's the risk of bleeding, which can be catastrophic. There's a risk of stroke. I think the first question is, are there minimally invasive solutions? And so we, of course, explored that with Jody, but to land a stent graft to cover that large diverticulum, you need a sufficient landing zone up by the neck, and we would have had to compromise blood flow to multiple structures going to the right side of her brain in order to land that stent graft, so that was off the table. And then the question is, do you really depressurize that big aneurysm sac, that diverticulum of Commerell, if you put a stent graft in?
What's a diverticulum of Commerell?
That's that large outpouching that then gave rise to the left subclavian artery you see coming off of the beginning of the descending aorta. So we knew that we had to eliminate the pressure going into that, and so we had to get it on both sides, both from the left neck and from the right chest. And once we did that, we knew that we'd have some residual fluid in there, some blood in there that would get reabsorbed over time, but it wouldn't be under arterial pressure, and ultimately that's what would improve her symptoms of swallowing.
We often hear from your patients, Dr. Crawford, that your care team, it's so impressive how you all collaborate with all the different people and experts we have at the health system. And I want to share something from Jody's husband, Steve, that he said about that.
The thing that amazed me is that when they're sitting there talking, because they're thinking about what they want to do, and you can see their brains are going, and they're kind of hashing over each other, like, what if we did this? We could probably do, of course they're using medical language, she knows more about it than I do, but and it's like, yeah, maybe that we can do that, And I thought that was really amazing.
Just watching them.
Just to see them bounce off of each other.
It is cool to hear. It's cool hearing it now from someone who didn't go through it, but you were also tickled at watching them bounce all these ideas off how they were going to fix you.
Oh yes. It was neat because you could tell they both were excited to figure out to solve my problem.
Right, Dr. Biggs and Dr. Crawford.
Yeah.
And when they finally landed on a solution, did you understand what was happening? Because for a lot of people, medical terms are like a whole foreign language to them. Were you able to understand what they were going to do?
Yeah, I knew what they were doing.
Okay.
Yeah.
And how did Dr. Crawford manage to put you at ease? Because you were in a precarious situation.
Right. He just has that calming effect when he comes in. It's like he's your old friend.
Right.
Yeah.
I noticed you patted him on the shoulder when he sat down.
Yeah.
Hey there, buddy. Which is awesome. I love seeing that. We have some great questions coming in and comments from our community. So I want to put my glasses on and get to those. First, we'll start off with Jim. Jim wants to know, what type of imaging was it that showed the aortic arch when we put that up on the screen?
Yeah, so that's called a CT angiogram. So it's a fancy CAT scan or a CT where we inject dye into the vein, and then we time the scan so that the arterial phase is lit up, so that the aorta and the aortic arch are lit up by the contrast that's administered. You can also see, sometimes kids are born with this and they have what's called a vascular ring, or an additional vessel that's constricting the esophagus and the trachea, and they get symptomatic real early in life. They have difficulty feeding or respiratory infections, and so that can be found on echo as well.
How would a parent know to ask that? Because kids can be real fussy with not wanting to eat things anyway, or a little baby, or...
Yeah, this can be more pronounced, regurgitation after eating, difficulty breathing, or loud, noisy breathing is kind of the classic description.
Jeremy Yenser has a question. Jeremy writes, I always associate aneurysms with the brain, and you hear they're like a ticking time bomb. Is an aortic aneurysm similar in that it could rupture or grow and cause further problems?
Yeah, so aneurysms can occur anywhere in the body, in our arteries, and so you know, essentially these arteries are tubes and they're pipes under pressure, and so when they're subjected to stress over time, then they can grow, and pathologic growth is what we call an aneurysm. So any aneurysm could potentially rupture, but we know that size is kind of the best indication of that risk of rupture.
Bob Diebert wants to know, Jody, post-care, do you need to take medications to help forever? Do you have to take any short-term? Are you on meds?
I am on meds, yes.
For this? You don't have to say all your meds, but
I
are you
think
on?
so.
Yeah,
I have 2 of them.
I know.
Yeah, for the graft, we just use aspirin, just a baby aspirin.
Really?
So.
How long do you take baby aspirin for then?
Forever?
Yeah, indefinitely.
1 a day?
Yeah.
And then what would be the other medication that you have to take after this?
Blood pressure medication, and then, you know, occasionally, you know, patients like Jody will have acid reflux, so sometimes they take medication for that. You can hear Jody's a little hoarse, and that's pretty common after surgery. We're working around some important nerves that control the voice box. So.
Have you noticed that your voice is getting better?
Yeah.
Gradually getting better and better?
Yeah. Yes.
And Jody mentioned before this program that she works in a warehouse. You're going back to the warehouse on Monday. Will you be lifting things?
Yeah, I'll have some lifting, but I also have a lot of help.
Is it okay that she's going back to lifting things?
Absolutely. She's 3 months out. Her scans have looked great, so she's from us. She got the all clear.
Marie has a question for you, Jody. Marie wants to know, was the asthma diagnosis totally wrong? Did you ever have asthma?
I did.
Okay.
I did.
Was most of it still being caused
Most of it was being caused by that.
by the aneurysm pressing on your trachea?
Yes. Yes. But I did have asthma.
Okay. I would love some final thoughts from our guests as we wrap this program up. Jody, I want to start with you. What would be your message to viewers, or what you'd like Dr. Crawford to know?
If you are experiencing anything different, be sure to have your doctor check it out, just so you're not suffering. But thank you so much.
Yeah.
You gave me, I came and it makes me want to cry.
Here, we have tissues for that.
Thank you.
Slide this over.
Yeah, but you've been awesome, and this experience has been like a 180 from last time especially, but I love how you let me know exactly what you were doing. And always treated me like I was a partner in this solution, so made me have a voice.
And that's what Steve was saying, and you and Steve, that probably made the brainstorming in front of you a comfort too, because it wasn't something done behind closed doors.
Right.
Dr. Crawford, what would be your message to viewers who are watching this?
Well, you know, as you're probably hearing about the brainstorming, I don't pretend to always have the answer up front, and I think transparency is important. You know, this was a high-risk operation, and we kind of put it out there for Jody that, you know, this is not something we do every day. There's certainly more risk involved, but we had a thoughtful approach and that we thought would give her a durable solution for this problem, and then we could do it safely. And so I appreciate her trust, and I think, you know, it's a rare reason to have difficulty swallowing, but for patients out there that maybe aren't getting the answers that they're seeking or are still struggling, you know, it's worth investigating, because it does happen in about 1 in 1,000 to 1 in 10,000 people that have this dysphagia lusoria.
Real quick, we do have a question from Jonas. He wants to know what kind of camera you use to take the pictures of the heart.
Honestly, it's my iPhone camera. I usually have my team come over and take pictures. So
You take off the gloves, you're all done, and you say, here you go?
Well, I'm not a great photographer, so I usually just step out of the way and.
Oh, and your team will take the picture?
Yeah, and they take the picture for me.
Okay, that would be a really cool job, to be the picture taker post-surgery. I feel like I could do that. I don't want to be in charge of someone's life, but I could take the pictures.
It's a lot of pressure.
Your iPhone must be filled with fascinating footage. Thank you both so much. Jody, thank you for coming down here and taking the time to join us and share your journey. Dr. Crawford, we know you're in hot demand as a surgeon, so we'll get you back. We'll get you back to your work. If you would like to watch or share any of our previous episodes, just scan the QR code on your screen. It will take you to links of all of our previous programs. Coming up next week on All Things Heart, doctors said Alex Lovely was a walking stroke and heart attack. Yikes. His blood pressure was dangerously high no matter what he did to try to lower it. You'll hear how his doctor here finally diagnosed him with the rare condition causing that and the procedure that fixed it. That's next Thursday at 8 a.m.
Coming up tomorrow on the Morning Medical Update. Some of the most meaningful moments in a hospital don't have anything to do with medicine. I'm Jessica Lovell on the next Morning Medical Update. The gestures that are more than medicine, a surprise party and a wedding wish. How staff pulled off both on the same day on the same unit. Friday at 8.